Hey guys. Hey Facebook and Instagram family. Well, not Instagram, Facebook and YouTube family. I do hope that you're having a wonderful, today should be Thursday. So a great Thursday. And hey, Built to Win community. You know that we love you guys, and we had a conversation about what is it we want to talk about? How do we make our community stronger? How do we make our community better? How do we do more for the community, which is the Built to Win? And one of the comments rather, that kind of had a string of us having a conversation was us talking about women's health as it pertains to fertility and just having like an honest conversation. So we decided to put together like an OBGYN appointment for you guys so you can come, we can have the conversation. But Dr. Lane is running a bit late because she had a few patients to deal with, so she's on her way here, so I'm super excited. So in the meantime, I just wanted to interact with you guys, see how you were doing, check in, say hello, ask you how your Thursday was going as we wait for the beautiful Dr. Danielle to come and chat with us today. So I'm pretty excited to have this conversation with you guys. Again, my lighting is not the greatest today because I only have one light, and that is 100% my fault. I was supposed to have my second light, but I didn't have my second light. So we've been lit in one direction today because there's no second direction lighting. So half of my face is looking dark, but y'all know what? This is like really cool because people try to take pictures like this, so I'm like doing it. So I can't wait when I get off here to hear what Tia has to say about my lighting today. Probably won't be good things, but that's okay. That's okay. So if you're in here and you'd like to say anything, please go ahead, leave a comment. Let us know if there's topics that you want us to talk about in the Build to Win group, conversations that you would like us to have, questions that you would want to know about today, anything pertaining to your OBGYN visit that you're either afraid to ask your OBGYN, have never asked your OBGYN for reasons of I don't have an OB, or I'm afraid to ask my OB, or I'm ashamed to ask my OB. Or like me, I always forget to ask my OB stuff, and then when I leave, then I'm like, should have said that. And then by the time you pull back, So we're going to create an opportunity for you today to be able to ask us questions as soon as Ms. Dr. Danielle joins us. So in the meantime, I should have had like a whole DJ session going on. That would have actually been really cool and played music, but I didn't think about that until now. So there's nothing I can do because it was an afterthought. But next time I'm going to get a whole DJ so that we can see and, maybe even chat with the DJ and see what's going on. All right. So again, if there's any questions you would like to ask, just please go ahead and pop it in the comment because we just really want to know so we can have those questions. If you're shy, you can go ahead and probably send me a DM, text message if you have my number, WhatsApp, Instagram, whatever means. You can send me an email at info@tamikamarshall.com with your questions, and we'll be more than happy to answer it. In the meantime, while we wait, I am going to switch up and kind of share with you a little bit of a positive message. Hopefully it's applicable to somebody's life today and you would enjoy it. So here, I don't know what you have been working on goal-wise, dream-wise, mission-wise, vision-wise, even trying to attain academically. But what I want to encourage, and it's something that I've always encouraged people to do, is follow your dream and go hard for it. Nobody's going to go as hard for your dream like you are. And, constantly we're always trying to get somebody on board our ship, on board our vessel, get them in the car, take them along for the ride. And when they don't want to, we're upset, we are irritated, we feel like our friends and family are not supporting us. But the truth of the matter is, that is not what you need. If you cannot convince me that your dream is worth fighting for, I'm not going to help you fight for your dream. I'm not going to help you fight for the things that you are not willing to fight for, or that you're not going to show me you're going to work hard for. So you need to sometimes, because it's not somebody else's dream, it's not somebody else's vision, it's not somebody else's goal, it is not somebody else's long-term plan. You need to sometimes show up for yourself as if it's 10, 20 of you cheering on. Okay? So whatever it is today, I just want you to keep going for it. Keep muscling through. Keep moving forward. It is your birthright to be amazing. It is your birthright to be great. And even if you want to just flip the script, right? The Bible literally says, beloved, I wish above all that you may his prosper and be in good health. And if God wants you to prosper, therefore, you have to do things to be successful, okay? So you have to work hard, study to show yourself approved, get on the grind, get it done. Don't be so fearful about moving forward. Don't be so fearful to win. One of the things that I learned is sometimes people are not fearful of the dream, but they're fearful of what the success of the dream will do to them. But don't worry, if you work towards the dream and then you stay grounded, stay humble, constantly be in a position of gratitude, you'll be all right. I promise you that. A lot of times, what happens is simple. We start achieving the things and then we get cocky. That's where the whole issue comes. We get arrogant. Nobody can tell us nothing. That's where you have a problem. But if you work for the goal, achieve the goal, crush the goal, and set new goals, and you stay humble, stay trusting, stay happy, I guarantee you, you'll be okay. You know, one of the reasons that we created as we were waiting, I'll have this conversation with you, the Build to Win community is so that, because when I migrated to the US, I didn't have somebody to have the conversations with me about jobs and school and what I can do. And when we left Guyana, there was only certain, in most countries outside of the US, jobs are limited because of the economy and what it's required from the economy. I mean, so you don't have this vast job market like you have in the US. And I don't know where else in the country, but I'm only speaking for the US. And when I came, everybody was like, do nursing, that's the thing. And this is not to knock or say anything bad about nursing, because we need our nurses, our RNs, we need them. They're amazing, okay? And everybody was like, do nursing, but I knew that's not what I wanted to do. But because the information was not there, I didn't know what I wanted to do. I didn't know what to search for. I didn't know how to find it. I didn't know if I would ever find it. I couldn't figure out if I'll ever get or become what I wanted to become. And after years of trying to figure life out, searching, doing research, starting school, deciding that's not what I want to do, switching majors in college, which was a major blip in my life, switching majors anyhow. But it's kind of like trying to find what you wanted to do in life. And finally, I started to find what I wanted to do in life. But it took me this long journey to figure it out. Whereas if I had I'm about to sneeze. Oh, excuse me. Okay, sorry. Whereas if I had the information, the people, like from the beginning to kind of guide me and help me to teach me, I wouldn't have taken that long. So we kind of created the whole idea of Build to Win the community is for when we migrate to the US and we don't know what schools to go to, we don't know how to get what jobs, we don't know how to find jobs, we don't know how to connect to professionals, we don't know how to connect to creatives. And it's something that I've done for the longest while, and I just want to be able to create an easy connection for professionals, creatives, to connect with someone that is now trying to get into the industry of any side of it, whether I'm connecting you with a doctor, whether we're connecting you with a pharmacist, whether we're connecting you with an entrepreneur, a creative, a photographer, but somebody that could help you get on your journey faster and give you the information quicker. Because school is great, but I'm telling you, there is nothing better than real life experience. And constantly we see on resumes, they're always asking us for real life experience, but bruh, I just came out of school. How am I going to give you 5 years of experience when nobody wants to give me this experience? And it's kind of the conversation I've always wondered, like, where am I getting this experience from that these people are so requiring? How am I meeting these people to get this information, to get this experience? So Built to Win really wants to help in that aspect where we'll connect you. You'll get to be a part of panel discussions, conversations, and just see where you are and meet you with your need to make it better for you, the consumer, and us. Basically, that's all we want to do. We just want to make your life easier. That's the whole idea of Built to Win. Making our lives easier, because I firmly believe if you build on a firm foundation, firm solid foundation, you'll be all right. I mean, then you can't shake, you can't shift. You'll be okay. You'll enjoy life and you'll be in a better, happier space. Okay? So, so let's see here for a second. Ooh, I clicked out of my room. Okay, bear with me 1 second. Okay, so I'm going to go make a quick check. Yes. And okay, apologies for that. So, and yeah. So if you can, again, I know already I'm seeing some of you sending me messages in my DM about what you want to talk about, conversations that you want us to have within the Built to Win community. Go ahead. Don't be afraid to send us an email to let us know. You can send me, again, you can DM me via Instagram, via Facebook. You can send us an email at info@tamikamarshall.com. And forgive me while I'm fidgeting with my phone. I'm just trying to read the emails at the same time. Okay. All right, yeah. So make sure that you do those things for us as well, because the whole idea is that we want to be able to, the whole idea is that we want to be able to build a community of strong, wise people. We want to make sure that whatever information that we have, whatever knowledge that we have attained, we are allowed to share it. You know, a lot of times I hear people say, they don't want to share what they've learned. They keep it in their head. And I'm saying to myself, to do what? If you've already used the information, everybody processes information differently. So go ahead and share the information, share the wealth. Let everybody be a part of, let everyone be a part of, bear with me 1 second. I appreciate your patience with me. Okay, so we're getting ready to have Dr. Danielle join us, and I'm super excited to have this conversation. She literally, during the pandemic, she started doing like these really cool videos on Instagram to talk about women's health. That's like the way I'm gonna put it for right now, women's health. And I learned so much. I have been going to my OB for over a decade, and A lot of times they would talk to me in terms I did not understand. But listening to Dr. Danielle, I learned so much about my health, my body. So I'm excited to share her with you guys, for you to get to ask your questions, for you to talk to her, converse with her, and we'll take it from there. Okay, bear with me one more second. She's just having a little bit issue getting into the room. So bear with me while I just go ahead and resend the link. Yeah. All right. So there we go. And we resend the link and let's see how it goes now. Perfect. All right. So of course you can get an appointment with her. Once she comes up here, you will definitely be able to ask her how to get an appointment with her. But yeah, I mean, that's the whole idea of things that we also want to do. It is connecting you with people that you feel comfortable with. And it's not that I have to take this information from somebody that I'm uncomfortable with, but it's to build a good relationship where you have some level of trust with the person. And I'm super excited because Dr. Danielle is here. I'm going to go ahead and bring her up. Hi.
I am so sorry. I've literally been sitting backstage someplace for the last 15 minutes. And it said last
Oh, wow.
it's exactly like this, except there was no you. But I've never been in this
Wow.
so I was like, all right, maybe this is it. Well, thank you for having me. And I guess I'll go with better late than never that we get to connect. I'm so sorry.
You are completely fine. I'm just happy that you're here and that we can have this conversation. Super, 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 super psyched about it.
Oh, thank you. Thank you so much. So, yeah, thanks so much for having me. And I know it's hard to, keep people engaged. So I'm happy to answer any questions that you have.
Great. I see that you're still at work. So thank you for taking the
I'm
time out.
always at work.
Oh, wow.
I mean, I think that when you're in practice with patients, to some degree, you're always engaged, right? Like, whether you're at your home or whether you're, thinking about someone in bed. I mean, I will say that maybe, and I'm not going to say this is the healthiest way to live your life, but I will say that it's typically that I always have someone in the back of my mind that I'm worried about, and then I'm thinking like, is there anything else we can be doing? Like, maybe we need to spend this a different way to make it better for them and get them a better outcome or whatever. So I'm, yeah, I'm physically at work now, but I think about medicine and I think about my patients a lot.
Gotcha. Fair enough. All right. Let's just jump into this conversation. And first, I want to ask you, got you started in making the Instagram videos that I have fallen and so many of us has fallen in love with?
That's so sweet. I started making Instagram. I actually started making TikTok, and I just started uploading them to Instagram. But I started doing that back in March of 2020. I was stuck at home with five kids, four of whom were teenagers at the time, and I was like, "What are these kids doing? They're dancing to their phone. Like, what's going on?" And it just and then I was like, well, that's never something I was going to do. But I started to look around TikTok and I saw that it was a good platform for disseminating information. And so that's sort of how it started. And I don't remember why I thought I should just also partner it on Instagram. I think what I came to realize is that there was no real easy way to communicate with patients on TikTok. It's a 15-second PSA, but there's no real good, clean interaction there. They have DMing, but it's hard to work. And so we started doing the same work on Instagram because it's easy to bring people over and they can have a conversation there that they couldn't have with you on TikTok. So that's sort of how it started. And it just kind of went from there. It kind of grew from there.
I love it. Well, I'm in love with it. It was one of my friends that shared doing the stories earlier on last year. I was like, I'm learning so much in these short videos.
Snippets of information, right? Yeah.
Gotcha.
I mean, they're not meant to replace, and I think that's really important. Like, it's not meant to replace your interaction with your physician. And so I get a lot of people asking me questions on direct messaging on Instagram that I'm like, look, it really depends on your specific situation, and I just don't have enough information to be able to give you an outcome on that, or a plan on that. And I think people don't necessarily always realize that, we really are not in a position where we can give medical care over social media. I mean, thank God, right? But we can give people enough information that hopefully they have the right tools to ask the right questions to get more clarity on their specific situation. And I think that is the goal. When we do the work we do.
Love it. Perfect. So before we even jump into it, somebody asked, and I'm pretty sure it's probably that they saw your video. How can they book an appointment with you? So we're gonna
Oh,
even just do that part.
yeah. So yeah, I mean, I think there's a link on our website. I mean, sorry, on our Instagram that takes you to like a book now place, and then that pops up for us as someone that we need to contact. Also, sometimes people leave me direct messages. I will tell you that like it is hard for me to keep up with the tons of direct messages that I get, but I try really, really, really hard. But so there's a book now space on our Instagram. There is actually a direct message option, and there are people who are looking at that other than just me. And then our website, which is just Lane Fertility Institute, always has a place where you can request an appointment there. So any of those ways work for us. Like we have a team that will find you if you give us, an email address or a phone number to reach out to you on, and get you into the, setting that you need to schedule appropriately. So any of that works. But thank you for asking.
Oh, you're welcome. So before we dive into the questions, can you tell me a little bit about you and your backstory and how you even got into medicine?
Yeah, I mean, I am, I grew up in Cleveland, Ohio. I am married. I have 5 kids. I did not have parents that were doctors. My dad is a PhD, but in computer science, and my mom is a chemist who became a teacher when she had kids because it worked better with having kids and the scheduling and such. And I loved math and science. I mean, I just really did. And that might have been because I always had um I mean, I realize now that my kids are at this age that like I kind of had these built-in tutors, right? In many of my subjects because I had this, computer science dad and this chemist mom, and that helped. But I've always loved math and science. I struggled more with loving, like, English essays and rote memorization for like history tests, but whatever, I could make that work too. And so when I went to school, I went to McGill up in Montreal because I have a dual citizenship. My dad's Canadian. And I started out as an engineering student, and I kind of hated it. Now, engineering wasn't like the sexy thing that it is now. Like now, you think of engineers, and you're like, you're going to Google and you're going to Facebook, and you're like, like it's a much different place. But at the time, there weren't a lot of me's. Like there weren't a lot of people who wanted to get their nails polished and wear cute dresses and have cute shoes in engineering. And so I liked the work, but I didn't really like the community of people that I was with, and that just wasn't fun for me. And when I did my summer internship, I worked at BP in the old days, and they paid me like $5,000, right? So it was 1994, and I was making, yeah, I know, I see those eyebrows, and I mean now like that's not so much money, but when you're like a freshman after your freshman year of university, and you're making $5,000, like that's like wow, I hated it. Like literally every day, I hated it. I was like, okay, so this is just not for me. And so I switched to physiology as a major, and I was much happier. I liked learning about humans. I liked systems. I liked learning hormones. I liked, I mean, I did some work at that time. HIV was the big research topic. I was in an HIV lab, and I loved that. I just had a lot of fun in biologic sciences, and so that's sort of how I got down the path of medicine. Now, admittedly, I had parents that were in that era very much like you're going to be a doctor or you're going to be an engineer, but you're going to be in math and science.
I think you went out for a
Are you
moment.
still there? Okay. I
Yeah,
think you got to let kids pick the fields that they like to pick.
yeah.
And so I don't recommend forcing people into these fields. But I also think that as a community, we're much wiser about the breadth of options that are out there for our children than, we were maybe a generation and a half ago. So anyway, went to med school at the University of Pittsburgh because I got a scholarship there. And I was like, well, if I can do this for less money, I'm like all in. So I went there. My husband then, my boyfriend was at Dartmouth for med school. And that meant that we did a long distance relationship for really 4 years, probably 3.5, because we, all in, we did a lot of rotations at each other's school. But, 3.5 years, we were long distance before the era of email, guys, right? There was barely any email back then. So, like, you were on the phone and I was telling somebody the other day, like, this was when long distance still was calculated by minutes. So you
Yeah.
paid per minute. You were on the phone. Remember those days? And so we did a couples match for residency, and we both ended up at Yale. So we spent 4 years there. And then for fellowship, there was no couples match, and I ended up scrambling into a spot in San Francisco at UCSF, and my husband came along as well. And then we've been in San Francisco since then. So that's sort of how we got here. When I graduated from fellowship, there wasn't really a job for me in private practice. I was offered a job at Kaiser, but we talk about how there are 2% of physicians that are in the African American female population, right? We only make up 2% of the physicians. Well, there were like none in fertility. I mean, literally, I think I know the one or two people that were, maybe three. I can think of three. Valerie Montgomery Rice. There was somebody up at Boston IVF, and a woman, Diana Brumfeld, who has actually sadly passed away since then. That was it. Like, there was nobody in the field of fertility that were African American females, and there were maybe a handful of men. And so the private practices weren't really looking for people that looked like me, and so I couldn't get a job here. So I joined Kaiser. Didn't really like Kaiser because I wasn't. I was really into this sort of really patient-oriented care model that I had in my head, and Kaiser kind of wasn't doing that. And they also weren't really ready to start IVF. So I stayed there for about 18 months and went into private practice, and I've been in private practice since then. So, fertility's changed a lot since I've been in the field. I finished fellowship in 2005. It's now, some almost 20 years later. But I still love the patients that we get to take care of, and I love the work that we get to do. And it's like just fascinating to be in our field. I mean, we just have a really awesome field. So that's how I got here.
Love it.
Yeah.
All right. So I'm gonna ask you. We're gonna jump right into it, and I'm gonna ask you the first question. And so our questions is gonna be, because it's just people submitting their questions, so it's gonna be all over the. It may not be a trail, but we're gonna get.
Okay. Let's do it.
First question: is birth control really safe?
I think in general, birth control is safe. So the specifics of that answer have to do with what type and who you are, right? So the purpose of birth control is to prevent you from getting pregnant most of the time. Okay. And from the perspective of that being the goal, I would argue that birth control is safer than getting pregnant and having outcomes that you don't want, right? Whether it's serial, terminations or more kids than you feel like you can take care of, like, right? So I think, and the other piece is birth control is broad. It can be using a condom, it can be using a diaphragm, it can be using an IUD, it can be using a birth control pill. And so generally speaking, all of those are safe forms of birth control. However, there are exceptions to every rule. If you're over the age of 35 and you're a smoker, then you can't be on birth control pills or NuvaRings or things like that because of your risk of blood clots, right? If you know you want to get pregnant again and, you've had issues with IUDs in the past, or you've maybe had scar tissue in your uterus in the past, that's not a great, birth control for you. Do you know what I mean? If you have issues with weight and metabolism and you're not willing to watch what you eat and you're not willing to exercise, putting you on a Depo-Provera shot may result in some weight gain for you, right? So I think a better answer is there is a birth control for everyone, and it's important for you to sort of, in a nuanced way, understand what your needs are and pick the right birth control pill for you or birth control option for you. Does that make sense?
I love your answer so much.
Yeah.
Because I'm a believer in that each person is different and therefore should not be given, everybody like give just mass information, and everybody takes the same information and processes the same way. So
yeah.
Answer.
And I think that sort of brings us to another point, which I really want to make sure we hit upon, which is that, look, guys, Um, Most of the systems of medicine in 2021 are such that you're not sitting down with your individual physician for, 45 minutes to an hour to share your story and make sure that they understand where you are, right? You might be seeing a mid-level provider who has perhaps not as broad of a scope of
Yeah.
nuanced care, and that is not to knock the mid-level providers. They're awesome physician extenders, but like if you have a specific issue and a specific scenario, they may not be able to address it. They might, but you need to make sure that you're getting to the right level of care. And you might be in a system that only lets you talk to somebody for 20 minutes. Like,
Mm.
so I think one of the challenges that we have as patients is to make sure that we get ourselves to the right healthcare system and the right provider for our needs. And I just don't always see that happen. And so then people consequently end up with outcomes that are not what they were hoping for, but it's because they didn't really get to see the person that they needed to. Does that make sense?
It does.
Yeah.
It does. Okay. How do you go about finding or knowing if you have an appropriate or a good OBGYN? I know it's
Yeah.
yeah.
I think that's a great question. So I think, one thing to sort of understand is that um, while we sort of all have the same criteria for what our training is, broadly speaking, and while we all sort of sit for the same board exams, if you will, right? Um, you know, Different programs are nuanced in different ways, and different providers are nuanced in different ways. So, for example, I trained at Yale, I told you this, and, where I trained, there were no general OBGYNs on staff. So what that meant is that everything we did, we saw through the lens of a specialist. And I mean, we did these long, debulking surgical cases that, like, most generalists weren't doing at that time, right? And so um, that's something that's sort of near and dear to me. But for a lot of people that didn't train that way, they're like, why would you do that, right? So I think understanding, sort of what your OBGYN holds as being important and what they're passionate about is one way of understanding if the person that you're connecting with is the right person. I saw a patient yesterday actually who, just clearly hasn't been in the right hands. Like she's gotten some workup done that has left out some very clear things that are important to her. But part of it is because she's been trying to get fertility care at a general OBGYN office. Well, that's just not the right place to be. So, I mean, I think understanding, first of all, what your needs are really important. Right? If you know that you want nuanced care around your contraception, then you got to make sure that when you're talking to your OBGYN that you're like, look, I need you to tell me what are the different options for contraceptives that I can have, and which one do you think is a good one that's specific to me, right? As opposed to the question being asked of you, like, well, do you want to be on birth control? And you say yes, and then they prescribe you some birth control pills. Do you know what I mean? So I think that nuancing that answer to meet your needs is an important way of figuring out if the person is a good fit for you. Another concept, I have had 5 kids, 4 pregnancies because I have a set of twins in there, and I really wanted to have a vaginal delivery. I had a C-section for a twin that was not doing well in a tracing, and so they did a crash section on me. And so the next pregnancy around, they were like, "Okay, well, let's do a C-section again." And I was like, "Okay, fine." I was busy about not paying attention. But then for my last pregnancy, I was like, I can't do that again. I don't have time to be recovering from a C-section. I want to do a vaginal delivery. I know I can deliver a big baby. I've had a big baby before. My first kid was 8 pounds and whatever. So I had to leave my OBGYN to go to somebody who was willing to listen to what I wanted and needed. And, that was a very specific case where I knew that I wasn't going to get what I wanted out of the current OBGYN group that I had. And you can imagine, like, I know these people. I mean, there's nowhere I'm going to deliver in San Francisco that somebody doesn't know me, right? So when I leave an OBGYN practice, it's not like I'm doing it quietly behind the scenes. Like they know I'm leaving, right? But you still have to know what's important for you. And at the end of the day, it was more important for me to have the type of delivery I wanted, that, or at least to be able to try, right? Because there are no guarantees in delivering. And if anybody thinks otherwise, like I'm going to tell you, there are no guarantees in your delivery. Okay. But you can at least put yourself in a space where people are willing to consider what your wants are in the context of having a safe mom and a safe baby. Does that make sense? And so I think making sure that you are clear about what is important to you and that you're asking the questions of your provider and at least hearing the answers that they put out. And if they don't put out the answers that you want, then go someplace else.
Mm, I like that.
Yeah.
Now, pertaining to that, one of the questions is how do we get our doctors to listen to our problems, symptoms, and concerns without having to look to change our doctors often?
Well, you may not. I mean, I think that's an unfortunate reality, right? You and I don't know if you have to change them often, but I think that you have to trial people, right? You need to go there, and that's what a consultation's for. A consultation is for you to get comfortable with that person and for that person to tell you how they work, right? And if those two things are a fit, like, then don't stay. I mean, I think the most common thing that I see on social media is people staying with physicians or medical systems that they're just not happy with. I'm going to throw Kaiser under the bus for a second here. They do amazing work for some things. Okay. And I worked at Kaiser. So I say this like having been there. There is nobody in this country, in my opinion, that rolled out COVID vaccinations better than Kaiser, period. But if you're trying to get fertility care at Kaiser, like that might be a challenge. They do it. And when
Yeah.
you finally get in, they might do it relatively well. But they've got like this. I can't even get myself on the screen to show you how many people they have. They have that many people and they have this many providers. So if you're looking for a nuanced experience in your fertility at Kaiser, like it's just not going to happen. And if you find that you're in that scenario, you may have to make a change in order to get the type of care that you want for your fertility care. I mean, there is no two ways about that. You, the individual patient, cannot change the healthcare system, and you cannot change the provider. You can change going to that provider, but you're not going to change the way in which they practice. I mean, I, as a physician, had to leave a physician to go to a different physician because I knew I was going to get what I wanted out of that practice. I mean, I know these guys. I trained with them from medical school, right? They weren't going to change. Do you know what I mean? So I think one of the mistakes that patients make is thinking that they're going to change providers. In other words, change how they practice, and then getting frustrated when that doesn't happen. So, the definition of insanity is, right, doing the same thing over and over again with somebody and hoping for a different outcome. Do you know what I mean?
Yeah.
Don't think that you're going to make that happen. It's just not. It's just the you don't have the leverage to do that as an individual patient in in any country really, but certainly not in our healthcare system. But what you do have, which is unique to our country, is the ability to pick up and go to a different provider. In most, actually, even within Kaiser, there are all sorts of different people who practice within Kaiser. You can't change the system, but if you don't like your OBGYN, there are like 100 others that you can choose from. And you may have to do consultations with several before you find the one that's a good fit for you.
Gotcha. That makes sense. I like
Yeah.
What are some tips that you would give to someone who is trying to conceive, has been struggling to do so over the years?
So I think the biggest challenge that I see with people who
You went out, your voice.
hold on, let me see if I'm back.
Yes.
Okay. I'm gonna pause for 1 second. Let me see if I can make this work. Hold on. Can you do me a favor? Are you on the phone with somebody? Are there any other patients here? Okay, I'm moving out of the exam room back into my office because I feel like I'm really, I need you to call a number for me. Yeah, I'll go by mom. Okay. There, now I can see everybody and I'm in light and this is much better. The biggest thing that I see with patients who have been trying to conceive is that they are not seeing a fertility specialist. If you are having challenges conceiving, find somebody who's a fertility specialist. Stop trying to get your OBGYN to solve your fertility problems because that's not their background, right? We have spent, 3 years after our OBGYN training just learning about fertility. And so it's almost not fair to think that the OBGYN is going to be able to do it. Now, here's why people stay. They stay because they think it's less expensive. Like they're like, well, I can get this ultrasound done for free under my insurance. I can get this done. But what really happens is they end up taking longer to get to the outcome that they want because they're not actually getting the care that they need. Does that make sense?
Mm-hmm.
So if you have a fertility issue, if you are under the age of 35 and it's been more than a year, if you are 35 to 38 and it's been more than 6 months, if you are 38 and over and you want to think about trying at all, pick up the phone, have a fertility consultation. It might cost you a couple $100, but it'll save you months of your life. That's the answer.
So just for us to have it, I'm gonna ask the question. Just for a clear definition, what is the difference between the fertility specialist and the OBGYN?
So an OBGYN has done 4 years of residency and is trained to do general obstetrics and gynecology. That means he or she can do everything from a general pap smear to a hysterectomy to let's see what else, delivering a baby, to DNCs, to think about them as the triage of all OBGYN problems. Of course, they're not triage nurses. They are actually far more trained than, a triage person, but they are meant to be able to do all of that stuff. Okay. But they are no more nuanced in managing fertility care than I am in managing gynecologic cancer care. Do you know what I mean? Yeah. There are a handful of subspecialties in the field of OBGYN, and here's what they are. Urogynecology, so for the folks that are having problems holding their bladder and they're leaking, or they, gotta go when they cough or sneeze. Remember, you've seen those old commercials? That's urogynecology, okay? High risk OB. If you've got a complication to your pregnancy, maybe you have diabetes coming in, or you have triplets, or you have preterm labor that isn't resolving, or you've got a cardiac condition before you get pregnant. That's maternal fetal medicine, which is the same as high risk obstetrics or obstetricians. Okay. There is reproductive endocrinology and infertility. And that is people who are trying to get pregnant. There's some other part. Reproductive endocrinology is actually more than just infertility. But what we do in practice is infertility. People who aren't getting pregnant. And that's a terrible word. Maybe subfertility is a better option, a better statement for most people. That's, I can't get pregnant on my own. I need to use a donor egg, a donor sperm, a gestational surrogate. I want to test for Huntington's disease before I get pregnant. Like, any of these things fall under the fertility realm. And how we get people pregnant is different than what the general OBGYNs are trained to do, right? There is, what did I miss? Gynecologic oncology. So if you've got ovarian cancer, cervical cancer, uterine cancer, any of the gynecologic cancers, that is a subspecialty of people that do that work, okay? And all of those people that I just described have done a 3-year fellowship in their specific training. And then there's a group of people who do minimally invasive surgery, and those guys typically do a 1-year fellowship, right? And so if you are talking to somebody who says they do one of the things I just reeled off, and they have not done a fellowship in that thing, unless they're like 60 or 70 years old and they predate fellowships, okay? It's 70 and up now, I think. Then they're just a general OBGYN who has a passion for that area. And I'm not saying that's bad, but do not confuse that with somebody who's a subspecialist in that area. Does that make sense?
Yeah.
Okay. And I think that's an important distinction. And I'm not knocking the generalists. God, we need them. Like, I'm not interested in doing their job, right? And most of them, frankly, aren't interested in doing mine. But from a knowledge perspective, it's hard for them to be nuanced on how to do a Clomid cycle, or how to do an IUI, or when to, recommend somebody to go to IVF, or, what are the most recent protocols that we're talking about, or what is InvaCell? Like, that's just not their space.
I can understand that. So I'm glad that we were able to clear that up.
Yeah, I think that's super important.
When trying to get pregnant, is there specific foods you should or should not eat? Specific clothes? Because I've seen on the TV they say men shouldn't wear certain things, women shouldn't do certain things. So is there any myth that you can burst or prove that you should either eat something, don't eat something, wear something, or don't wear something? That would kind of.
So I am not familiar with any clothing that will impact your fertility significantly. Now, I'm going to say the caveat to that is historically we've talked about tight-fitting briefs in gentlemen, but just get the semen analysis. Like, if the semen analysis is normal and your guy wants to wear briefs, I mean, that's not what's keeping you from getting pregnant. Do you know what I mean? So, it's a great general statement that applies to very few people. If you're Lance Armstrong pre his testicular cancer and you're like riding hundreds of thousands of miles in your tight fitting briefs on a bicycle seat, sure, he might have low sperm, but he's an exception to the rule. And I mean, even in San Francisco, where I lovingly say people, exercise, eat water, and drink air. I mean, we still don't see that as a huge problem. Do you know what I mean? So I think that's an important point. In terms of food, I think much more important than the food you eat is sort of the general health of your body, right? So specifically with food, people have talked a lot about um, a low carbohydrate diet. So that data is specific to the polycystic ovary syndrome studies of women that have elevated body mass indices and have the ability to decrease their weight by being on a low carbohydrate diet, and sometimes we'll see an improvement in their ovulation, right? So if you are a polycystic ovary syndrome patient with an elevated body mass index, with a high insulin level that's pre-diabetic and not ovulating, if you're that person, you should be on a low carbohydrate diet. By the way, you should be on a low carbohydrate diet even if you're not trying to get pregnant, because the goal of that is to actually help you decrease your body mass index and like step further away from the risk of developing diabetes, right? That is what that was about, okay? Or here's another example. If you know that you have celiac disease, okay, and you are interested in trying to conceive, you should be on a gluten-free diet because it decreases inflammation. By the way, if you have celiac disease, you should be on a gluten-free diet anyway. Do you know what I'm saying? So the people for whom there are specific eating recommendations are generally the people who have specific dietary needs, right? Yes, if you're trying to conceive, you shouldn't be drinking a lot of, alcohol. I mean, frankly, because you're not going to know when you first get pregnant. Yes, if you're the person who's trying to conceive, we don't want you using marijuana. We don't want you smoking tobacco. We don't want you, eating a lot of high mercury fish. We don't want you eating unpasteurized foods, right? But none of those things are going to get you pregnant. Do you understand what I'm saying? Those are things you should be doing in the space of trying to be in your healthiest state for pregnancy when it occurs. But they're not the things that typically get you pregnant. Does that help?
It does, because you're bursting like a lot of myths. Like, you see a lot of things in the television, they tell you this, so it's kind of like things that you really want to know. It's like, even when you're pregnant in the movies, you would see the girl would give birth and then her belly goes back flat and everything is right with the
Yeah,
Lord.
that's a myth. I remember my first pregnancy. I showed up and I had my cute little postpartum outfit that I was going to wear, and I was an OBGYN resident, so I should have known better. But anyway, my mom came with me, and I was like, Mom, I have this cute outfit that I want to wear postpartum. And she was like, Sweetie, you're going to be wearing the clothes you came in with. And I was like, what are you talking about? I'm like, you don't know anything. Let me tell you, I wore the same clothes I walked into the same maternity clothes I wore to the hospital, I wore back home. And I also will tell you that there are, I've not seen this, but I also not in the labor floor anymore. When I was a resident at Yale, there would be women who would come in and whose mothers would bind them before, from postpartum minute one, and they would leave bound, like with a binder on. I mean, if that's your culture and that's what you want to do, I'm not knocking it, but even those women had a hard time fitting into the cute outfits after their delivery. So yeah, don't do that to yourself.
I understand, yeah, because I like have this conversation and kind of I don't think this. I'm pretty sure it's not a word, but demyth some things. Prove some things wrong, because oftentimes you see it and it's being shared. It's the content that you see out there. So it's kind of like, how do we then decide what's right, what's facts, and what's not? And you have sites like, forgive me, but Wikipedia that posts whatever it wants, and you can just search whether it's factual or not. So I'm glad to actually have this conversation to really ask these questions.
Absolutely.
With someone that has had something pertaining to, I'm sorry, my phone just went off. Sorry. Somebody that has had, maybe, I'm gonna say just vaginal, some issue with either that vaginal area or their ovaries in the past, is it harder for them to get pregnant than somebody who just had a healthy um, ovaries in that area consistently? Hopefully, I'm asking that question correctly and you
Okay, what
understand.
I think I heard you ask was if you've had problems with your ovaries in the past or your
Hmm.
uterus in the past, should you expect to have more difficulty getting pregnant? I think that's what I heard. Okay.
That's
So
what's.
I'm trying to think of an example of a problem that you've had with your ovaries that would make it difficult for you to get pregnant. So I
Mhm,
think here's what I would say. If you've had any procedure on your ovaries or your uterus, it's worth a conversation. And you can start with your OBGYN, right? But it's worth a conversation with someone about how that may impact you. I think the reason I would phrase it that way is because if you, for example, I had a patient who had a dermoid cyst. That's a benign cystic structure, but we always take them out, right? We're going to take them out and double check that it's a dermoid and double check that it's benign and that there's no components of it that are concerning. We also are going to look at the other ovary. When we do a surgery on an ovary, there is a chance that we may take away enough ovarian tissue that's really, really difficult for that ovary to behave well, right? And so in that setting, we might find that somebody has a low anti-Mullerian hormone level or a low antral follicle count after the surgery, right? That's somebody who may have a hard time getting pregnant. Okay. And I'm thinking about a patient that we had recently who that was exactly the case. Her one ovary they had just taken out altogether when they took out the cyst, and the other ovary, gosh, it just wasn't behaving as well as we wanted to. So she was very wise to immediately be seeking help because of that. I would say most people who have a scenario like that know that that's their scenario. A second scenario can be people that have had, talk about you work to your uterus. So if you're somebody who has fibroids and you've had a lot of surgery around your fibroids, yeah, we should be looking at your uterine cavity and making sure that it's both competent, that there aren't any scar tissue issues inside your uterus, that there aren't any new fibroids that develop. Because if you once a fibroid maker, always a fibroid maker. Do you know what I mean?
yeah.
So yeah, those are things we should be looking at in your specific cases. I think anytime you've had that sort of gynecologic work, I would hope that somebody has suggested to you that it's at least worth having a conversation with somebody to consider whether there are more things that could be a problem because of that, right? But I'm not sure that always happens, is the answer to your question. So I think in general, back to my original conversation, if you're even thinking that there could be an issue, it costs so little. It's a couple of $100 to talk to a fertility specialist, even if you have no insurance. And it is so much work to overcome the time delay if you haven't talked to that person and we turn around and find out that there's an issue. Does that make sense?
It does.
That's how I would think about it.
I like that. I agree with that. I'm thoroughly enjoying my conversation with you. Before I go, I want to ask you two more questions.
Okay.
One of my question is, what is like the one? It's a two-part question, A and B. When would you recommend? Uh, Let me back up. IVF, right? Explain to me what IVF is and how it actually works.
So IVF is the idea that for whatever reason, we need egg and sperm to meet outside of the body. That's what in vitro versus in vivo fertilization is, right? So it's happening outside the body. Okay. And so we generally stimulate the ovaries. We do an egg retrieval, which is done under, some form of anesthesia. You're usually breathing on your own, no tube down your throat. And we then take the eggs out of the ovaries, right? And we put, and not all the eggs, just the ones that are available to us for that given month. So you're not getting rid of all your ovary eggs in this process. And then we mix them with sperm or inject them with sperm. And then we put embryos back into the uterine cavity. So that is what IVF means. Okay. The types of reasons that you get there are because the tubes are blocked. There's not enough sperm. There's an egg quality issue, which means that we need to get more eggs and sperm to meet so we can increase the likelihood of getting a healthy embryo. Or in 2021, because you want to know the genetics of your embryo before you put it back. You don't want to be at risk for miscarriage. You don't want to be at risk for twins. You just want to be able to put back one healthy embryo. So that is generally how we get to IVF. The other reason we get to IVF is if you know you have a diagnosis of endometriosis, best treatment is in vitro fertilization, or if you've tried other forms of treatment and not been successful, next step typically is in vitro fertilization.
Gotcha. Okay.
Okay.
If you've had an atopic, hopefully I'm saying it right, pregnancy, how
Ectopic.
soon, yeah, how soon after should you try to get pregnant again? Do you run the risk of it happening? I mean, obviously you would
Yeah.
run a risk. Does it become like a heightened risk of it happening
So the
again?
biggest predictor of an ectopic pregnancy is a prior ectopic pregnancy. I mean, period.
Mm,
Right. So, I guess the statement that I usually make is there are very few things that impact one fallopian tube and not the other. So from an REI perspective, from a fertility doctor's perspective, I can't really get behind continuing to try through your own fallopian tubes after you've had an ectopic pregnancy, because one, it's a risk for another ectopic pregnancy, and and two, it's a risk for your overall fertility and your overall health. So ectopic means that it is anywhere except in the uterine cavity, right? And
mm,
so that means that it can be in the fallopian tube, it can be sort of at the outlet of the uterus, it can be down near the cervix, it can be a bunch of places, but it's not where it's supposed to be, right? The most common place you find it is in the fallopian tube. And usually that means either opening the fallopian tube up and taking the pregnancy out and then repairing the tube, or, which again, not my favorite, or taking the fallopian tube out altogether. The things that cause ectopic pregnancies generally are endometriosis, which again doesn't impact one tube, but it's a systemic disease, impacts your whole body, but definitely more than one tube. Two, infection. So gonorrhea, chlamydia is the worst bad actor that we see typically. And again, that's not unilateral. It never impacts one side without the other. Three, previous surgery. So if you've had surgery on one side and not the other side, then in theory, if you have an ectopic on the side you have surgery with and not the other, okay, so I can get behind that being a reason why you can't, why you can see a normal pregnancy after that. But, you have to really do some digging to understand why you had the ectopic the first time and feel comfortable that you're not putting yourself at risk the second time. When we do ectopic surgeries, well, we don't always do surgery for them. Sometimes we do medication to get rid of ectopics today, which, benefit is you're not having surgery. Problem is we may be setting you up for another ectopic, right? But when you do an ectopic surgery, there is some risk to the surrounding organs, which include your ovaries. And so you'd prefer not to do that under the circumstance of having, this bleeding scenario in the middle of the night, which is always when ectopics happen, right? Your ruptured ectopic always goes at like 9 o'clock at night and ends at 1 a.m. So, that's not the time to be doing prophylactic surgery. That's the time to sort of get the tube out, stop the bleeding, keep the person safe, and get out of the pelvis, right?
yeah.
And so you will be hard pressed to find somebody who takes out both fallopian tubes at that time, because that's essentially sterilizing someone. And you know how we feel about sterilization. And yes, you can always bypass that with IVF in theory, but in reality, if you can't afford IVF, I've just sterilized you, and you don't have a recourse. So that's why it's hard to get people to take out both tubes. But the flip side is it's really hard to justify going back to using your tubes, in my opinion, if you've had an ectopic pregnancy. It's a slippery slope in our field, and the reason is mostly based on cost, right? I think that if we were a country that had, fertility coverage for everybody, we would feel a lot better about being able to say, look, this fallopian tube didn't do its job. We should just be doing IVF. Let's get rid of these tubes and move forward. But we don't have that. And so it's hard to talk people into that, rightfully so, because what is their way of getting pregnant otherwise? Do you know what I'm saying?
I understand that. I really
Yeah.
do.
That's a tough one.
So the thing is, actually, today is the first time I'm actually learning that fertility is not covered under insurance. I actually didn't know that.
Well, it's not for everybody. So, I mean, here we are in the Bay Area in the middle of a bunch of really wealthy tech companies that offer these benefits to their patients. I mean, there are companies that, have $125,000 per lifetime max per employee for fertility. So yeah, and there are also states that have mandates for fertility. So if you live in Massachusetts, or if you live in, I always get this wrong. I think it's Maryland, not Virginia. If you live in New Jersey, like these are places where you have coverage for in vitro fertilization cycles, right? But that is less of the norm for the majority of the country. And even within those states, there are criteria, right? Age criteria, how much have you tried criteria? Are you a same-sex couple who've tried with enough donor IUIs? If you have to do 10 months of IUIs to get coverage for your IVF, like goodness, just pay for the IVF, because I'm going to tell you the donor IUIs are going to be more expensive than a cycle of IVF. So no, we do not have mandated coverage, and we do not have good uniform coverage of IVF in this country. It's a problem. And I'll go one step further to say that the people who have access to coverage tend to be the same people who were going to have access to coverage anyway, right? So we are not, as African Americans and Hispanics and women, as well represented certainly you can work at Facebook and be a woman, but they don't have a ton of engineers that are women at these companies. And so the percentage of African Americans isn't high, the percentage of Hispanics is not, Latinx is not high, right? We do not have nearly as much representation in these places where there's great coverage as we'd like. Even in places like Illinois, you have to be working in a job with a certain type of insurance to have the coverage for the IVF, and if you're not, then just because you live there, you don't get it just by residency. Do you see what I'm saying?
Yeah, I understand. Sad, but I completely understand.
Problematic, highly problematic.
And for my final question, at what age did you start seeing an OBGYN? What you think is like a good age for you to like pop into and start to get your first checkup?
Yeah, I think the general recommendations are somewhere between 13 and 15 years of age, and certainly when you start having sex. So the first time you're having intercourse, you need to be seen in OBGYN, because that is when you first have your risk of HPV, which we now know is a sexually transmitted disease, which leads to cervical cancer, can be avoided by both, taking vaccinations around HPV, but also, through use of pap smears and HPV testing, more HPV testing than the pap smears, to prevent that. So if you're old enough to have intercourse, you're old enough to see an OBGYN for sure, and as young as 13 to 15. Okay. And if you're a mom out there, I'm a mom, I've got kids, I've got girls, 4 of them. If you're a mom out there, it's important for you to recognize that when you go to see that OBGYN, they're likely going to kick you out, and they're going to talk to your child about contraception and about safe sex and about avoidance of sexually transmitted diseases, and they're going to offer them contraception. And we believe strongly in that, because I'm going to tell you, the youngest child I've delivered was 13. And I will take the wrath of a mother who doesn't want their kid on contraception over delivering that 13-year-old any day. Right? So it is important to know that those things are happening, even at the pediatrician's office. From the time my kids were like 12, I'm politely asked to step out, and, and they have some conversations with my kids. And I think that, you're allowed to have any relationship you want with your child. You're not going to change that mandate around the pediatric or the adolescent specialists or the gynecologists, because, they feel strongly about that. And I think it is important to, make sure your child understands how you feel about certain things, but realize it's their first foray into getting, their own care and understanding what's important to their own health. And that can be hard as a parent.
Yeah. I have a son, so I can be patient.
I don't know about that.
I can be patient for a bit. But I thoroughly enjoyed talking to you. I do hope that we can do this again so we can get more in the. I didn't even realize it's been an hour already.
Well, I'm not sure I've been on the whole hour. I think I joined at like 17 minutes. So I'm really sorry, guys. If you're out there and you were waiting for me and I made you late to something, I really apologize. I, try and give my patients 110%. But that sometimes means that my timeliness is, challenged. So my apologies on that one.
Listen, I prefer you to be a real good doctor and help somebody, and they get what they need to get in and be a little late. I'm okay with that.
Fair enough. So I'm going to thank you again for inviting me to be on this. I'm sorry if that went away. I was taking a quick screenshot of us, okay, Tamika? So when you see yourself on my Instagram, you'll know how you got there. But I am really, I'm grateful that you allowed us to be on this and that you were flexible with our time. I'm so sorry again for anyone that I kept waiting, and I'm thrilled to have been able to be a part of this. Thrilled, thrilled.
Oh, well, I'm happy to have had you. Before we go, is there anything you say, any advice you'd like to give before we close out?
Yeah, I mean, I think the biggest thing that I heard here as a theme was the need for people to understand that you are responsible for your own care. You own your own care. You need to advocate for yourself. It is 2021. If you feel like someone's listening, not listening to you, then you need to get up and move. Go see someone else. That is so worth it. It is such a better path than being in an unhealthy relationship with a provider, right? I don't, as a provider, I don't want to be in an unhealthy relationship with my patient. And as a patient, you don't want to be in an unhealthy relationship with your provider. It doesn't work. It just doesn't work. So don't do that to yourself. Like, find the person that's going to be a good fit for yourself. And if it means you have to go visit 3 people before you pick someone, so what? That's okay. Better that than the opposite.
Right. So use your consultation, guys. Get to know it's
Yeah,
okay. But but again, thank you so much.
you are welcome. It's my pleasure. Thank you for your time.
Bye.
All right. Bye.